I welcome all of you to the 19th Annual Presidential Lecture. Each year, we gather and hear from and honor one of our most distinguished faculty members. Today, we're privileged to enjoy a lecture from one of our very best, Kathleen Buckwalter, UI Foundation Distinguished Professor of Nursing and Associate Provost for the Health Sciences. Your program summarizes the remarkable career and accomplishments of Kitty Buckwalter. Her work is marked by extraordinary talent. I must mention one additional characteristic that doesn't emerge quite as readily on a resume: Kitty's compassion. Her lecture today is entitled, "Who Will Care?" We're going to hear about caring for Iowa's elderly, not only from an expert on gerontological nursing, but one of the most compassionate human beings I know. Rather than repeating or expanding on the information in your program, let me present for you a few sketches that will help draw a picture in your mind of a woman of extraordinary talent, dedication, and compassion. First, picture a baby girl being born right here at our university hospital, Kathleen Cohen. Kitty is a dedicated Iowan and an Iowa Cityan through and through, literally from the day she was born. She grew up and attended school here. Her children were born here, and we're fortunate that she's devoting her career to our university. Next, picture little 6-year-old Kitty Cohen. Her many talents manifest themselves on the field as Kitty masters every little girl's dream activity: baton twirling. Through her talent and dedication, she soon moves from that cute kid dropping a sparkling baton in the 4th of July parade to president of the Iowa Twirling Club and eventually state champion. Now, picture a young lady on the stage, playing the violin with grace, beauty, and compassion. That's Kitty Cohen, whom many call a prodigy and headed for a possible professional career in music. It's no wonder that she was elected homecoming queen of University High School. Next, however, I want you to picture a young woman who makes a brave, startling decision. The country is engaged in a brutal war in Southeast Asia. This young woman wants to see the world, and she wants to help people. With a fresh nursing degree from the University of Iowa and an academic performance that earned her the Virgil Hancher Award, Kitty Cohen joins the Navy to apply her newly acquired nursing skills in Guam, Vietnam, and Cambodia. She repairs broken bones and treats severe wounds wrought by guns and bombs. She earns the rank of second lieutenant. She becomes an expert scuba diver. On weekends, she grabs a sleeping bag and hops aboard a refueling tanker for B-52s and wins her way back to Iowa to see her boyfriend, Jody Buckwalter, for 24 hours, and then darts back to Vietnam. Her 13-month tour of duty is up, and she immediately signs up voluntarily for another one. Her 26 months of bravery, care, compassion, and dedication in the Southeast Asian theater earned her decorations and recognition as Iowa Veteran of the Year. Next, picture a talented, experienced healthcare professional urged to go on to medical school and choosing instead to pursue a career in nursing. Now married to Jody, she spends 4 years on the Greyhound bus at 3 a.m. every Monday morning with her friend and classmate, trekking to the University of Illinois Chicago for her doctoral studies, bunking in friends' rooms. She nurses her firstborn child on the bus. Eventually, next to her Iowa Veteran of the Year award, Kitty Cohen Buckwalter proudly places a crystal Greyhound given to her by the bus company for best all-time commuter. Picture Kitty Buckwalter in more contemporary times, an accomplished teacher, a skilled administrator, and an internationally recognized scholar who is profoundly devoted to the tragedy and wonder of elderly people impaired by the slow devastation of dementia and Alzheimer's. For Kitty, these people are not simply textbook cases or journal article fodder. These people touch her deeply, and they inspire the dedication and compassion that courses through her veins. Picture Kitty in England in 1991, accompanying her husband to Oxford. Out of her simple yet expansive generosity of spirit, she makes her way to St. Luke's every day to volunteer her services to the mentally impaired elderly residing there. She empties bedpans, she feeds the residents, she bathes them, she holds their hands. Picture 2 years later, on a return trip to Oxford, when Kitty and Jody stop by St. Luke's. A nurse approaches an elderly man. This is hard for me. I think it represents what Kitty meant to people, that they remembered that she came back to see them after so many years, that she was back. Her 2 years there were immensely rewarding, not only for her, but for the patients there. But picture Kitty Buckwalter here today. Her dedication only grows stronger, her compassion only grows deeper. Her colleagues tell of the extra mile she walks for her students, her egalitarianism, her insistence on sharing credit, her relentless all-night grant-writing dramas that at one point resulted in a cast of 15 performing for an audience of 1. Kitty, a tragic opera in 3 acts, El Destino di Grant application. Her family will tell you of a daughter, wife, and mother whose love and devotion knows no bounds, a woman who will come before us today to share her knowledge, even though she has spent the past many months ministering love and care to her own ill father, who was buried only yesterday. The state of Iowa faces a crisis. We have one of the most elderly populations in the country. Our medical and elder care resources are stretched to the breaking point. Indeed, we must ask the question, who will care? I am enormously grateful, as well as proud, that Iowa has Kitty Buckwalter to help us ask and answer that question. We could ask for no better person to do so. Kitty not only talks the talk, she not only walks the walk, she lives the life. I hope my little sketches today here helped you see that. It's with very great pleasure to introduce our 19th presidential lecturer, Kitty Buckwalter.
Thank you so much. Well, Beethoven is a hard act to follow, especially when played as beautifully as it was this afternoon by our faculty trio. Bravo. I also want to express my appreciation to President Mary Sue Coleman and the Selection Committee for the honor of inviting me to address you on this topic, that it has consumed my interests and efforts over the last 20 years, and that in some way or another is likely to affect many of you as well. One thing that is certain about the future of elder care in Iowa, the need to improve both health and mental health care will become more pressing. The baby boom generation, which includes many of us in this room today, is in the midst of caring for their aging parents and beginning to think about their own retirement and old age. The financial demands boomers will place on the healthcare system will be enormous, as will their expectations for rationality and responsiveness. Our current system of elder care is unlikely to meet those demands. The demographics are also clear. Our society is aging and becoming more diverse. The number of people over the age of 65 will double to more than 70 million by the year 2030. And the percentage of people over the age of 65 will be approximately 20% of the entire US population. Here in Iowa, we already exceed the national average for percentage of population over the age of 65 and have a greater proportion of persons aged 85 and older than any other state. With the outmigration of young adults and the aging in place of elders in our state, this trend is expected to continue. Additionally, the number of elderly people with long-term care needs will rise substantially, from 8.7 million today to 12 million by the year 2030. And many of these will be people of color. The percentage of non-white elders over the age of 65 is expected to grow from 15% in 1995 to 34% of the older population by 2050. The healthcare services required by this fastest growing segment of our population are diverse as well, ranging from care in nursing homes to personal care at home. Our present long-term care system has a dearth of high-quality care options. As noted by Karen Davis, who's president of the Commonwealth Fund, we entered the 21st century without a basic system of financing long-term care, adequate standards that govern quality of care, or a shared understanding of the best approaches to providing care that is sensitive to patient and family preferences. The cost of caring for older adults is projected to grow from approximately $1.7 trillion to almost $16 trillion in 2030. From 38% of the total healthcare cost to nearly 75% of healthcare costs. Our aging population will present significant stresses on families, friends, and the communities who are responsible for caring for frail older adults. And this is especially true, as this slide illustrates, with regard to caring for persons with dementia. In addition, all social, housing, and transportation services will have to adapt to meet the needs of older people. But demography is not destiny. Our growing elderly population also presents important, though perhaps less obvious, opportunities. Old age is changing, and our perceptions must change with the new realities. We must increasingly view older adults more positively, as valued and valuable citizens, and as a significant strand of the nation's broader healthcare tapestry. Clearly, reshaping and improving healthcare is necessary in order to meet the needs of the growing number of older people. Older adults often do not get the care they need because our current healthcare system, and especially our mental health care system, lacks parity, is too fragmented, and services are uncoordinated. Addressing the medical, psychological, and social needs of older adults through research will enhance their health and quality of life. Providing better patient information and caregiver training can improve the effectiveness of interventions and increase rates of independence. As T. Franklin Williams, who's former director of the National Institute on Aging, said, "Research and care require each other. They interact with each other. They benefit from each other." And that is what my career as a geriatric mental health nurse has been all about, research and care. Now, because this lectureship was established to encourage communication across many disciplines, I want to digress a moment and share a story of how informal communication and support from many sectors and by many different individuals here at Iowa has facilitated the work I'll be sharing with you shortly. When I was undergoing review for promotion to the rank of associate professor in 1982, then Dean Felton gave me some sage advice. Get a focus and get some external funding. Shortly thereafter, I was attending a lawn party at the home of my colleague Joanne McCluskey Doctorman and chatting with Jay Semmel, then employed by sponsored programs, about ways to achieve Dean Felton's recommendations. As we parted, I asked Jay to be on the lookout for any grants or award announcements that might come to his attention that would both focus and support my beginning research efforts in psychiatric nursing. In less than 2 weeks, a campus mail envelope arrived at my office bearing information on how to apply for a Geriatric Mental Health Academic Award, or a KO1, from the National Institutes of Mental Health. So I thought to myself, why not apply? I meet the criteria for application, I like old people, and it will make the dean happy. So I put together an ambitious program of study that included 18 semester hours of coursework that would earn me a certificate in aging studies in the College of Liberal Arts. I submitted the application to the NIMH in October of 1982. but I was so naive about the research process and the workings of NIH that when I hadn't heard anything after a few months, I assumed I hadn't gotten the award. Then late one Friday afternoon in mid-May of 1983, Elizabeth Burns, one of the more seasoned researchers on the College of Nursing faculty at that time, stopped by my office to inquire about the fate of my application. I told her I guessed I hadn't gotten it, but I hadn't heard anything official. She urged me to call the NIMH and pursue its status, and so I did. Miraculously, even though it was after 5 p.m. in Washington, D.C. on a Friday afternoon, Dr. Jean Cohen, who was then director of the Mental Disorders of the Aging branch at NIMH, answered the phone and proceeded to inform me of my priority score and that my application would be going to council in a couple of weeks. Now, you need to understand that both priority scores and internal or institute advisory councils were pretty meaningless concepts to me at that stage in my career. But I do recall him saying, and this is pretty close to verbatim, "Don't jingle the coins in your pockets, but I think you'll start on July 1. I nearly fell off my chair. Not only was I 5.5 months pregnant with our third child, but I was scheduled to start teaching a graduate summer school course in research methods in just a couple of weeks. My friend Meridine Moss agreed to assist with the course, and off I went to Calvin Hall to register for fall semester classes as a full-time student in aging studies. Registration was perhaps the most difficult aspect of my postdoc. After 3 frustrating days of being rejected by the university's computer system because I did not have a degree objective and I did not have an advisor, I headed over to the graduate college to plead my case. Fortunately, Jake Jacobson met me at the door, created some sort of category that the registrar would accept, and named himself my advisor. Abby was born 3 weeks into the fall semester, and Dr. Glask gave me gay passes to go to class from my room at University Hospitals. Doctors Walls and Morris arranged classroom breaks so I could breastfeed her, and so with a lot of understanding teachers, flexible administrators, and supportive colleagues, I made it through. Those 3 years of postdoctoral study proved to be a pivotal point in my career. After completing my formal coursework in year 1, I used the next 2 years to establish clinical research sites in 3 settings throughout Iowa: the Knoxville VA, the Iowa Veterans Home in Marshalltown, and the Abbey Center for Community Mental Health in Cedar Rapids. The remainder of this lecture will focus on selected services and research that emanated from those 3 sites over the last 20 years, including a services research demonstration grant, the Mental Health of the Rural Elderly Outreach Project, a training grant for long-term care rural providers, and an R01 on family caregivers. Now next, I'd like to show some video clips. They capture the nature of my work and the population under study. Now, despite the 80s clothing and hairstyles, which I hope won't be too distracting or humorous to you, the video also features many of the people who have been instrumental in my career. And in fact, Woody Morris, who many of you know, is the only actor in this series. All other participants, used with permission, are real patients, family members, and colleagues in real settings.
Dr. Buckwalter received her Bachelor of Science degree in nursing from the University of Iowa. Upon graduation, she fulfilled a 3-year commitment in the armed forces as a nurse in the United States Navy and returned to graduate studies at the University of Iowa. Dr. Buckwalter graduated with her master's in psychiatric nursing from the University of Iowa. She received her doctorate from the University of Chicago in 1980. She returned to the University of Iowa as a faculty member, where she was encouraged to develop a focused research plan and seek external funding. Dr. Buckwalter's research projects were aimed at solving clinical problems with geriatric mental health patients in rural settings. Her work was conducted at 3 sites. Her first grant, Increasing Communication Ability with Elderly Aphasics, funded by the Robert Wood Johnson Foundation and conducted at Knoxville, Iowa's VA Hospital, was a collaborative speech therapy intervention. STEP, Speech Therapy Enhancement Program, was delivered by speech therapists and nurses to elderly residents with communication difficulties.
The Veterans Administration Medical Center in Knoxville, Iowa is about a 2-hour drive from Iowa City. It's a 600-bed facility located out in the middle of nowhere, as many old-time VAs are. It was a fabulous place for me to conduct research because they have nursing home units, 100 beds each, and they have a very dedicated staff who are eager to become involved in nursing research. I applied for and received a Robert Wood Johnson Foundation grant to study remediation of communication deficits in elderly patients at that site. And that was really one of the first large grants that I had received. And although it was difficult sometimes traveling the distance to the Knoxville VA, I found the level of support there and the access to appropriate subjects to be phenomenal. Well, it was a very interesting repeated measures design where we allowed people to be in the intervention study for a 3-month period. Then we withdrew the treatment for another 3-month period. Then we had kind of a sham treatment where we interacted with the individuals, but not on speech therapy per se, because we wanted to tease out the effect of just communicating one-on-one. We weren't sure whether we were actually contaminating our experimental design by spending more time one-on-one with individuals. And then we went back and repeated that design again, adding the treatment, removing the treatment, that sort of thing. We found that the intervention we tested, which was called STEP, for Speech Therapy Enhancement Program, an individualized intervention of nurses and speech therapists working together, could improve patient speech over time, as well as diminish some of the more adverse behavioral consequences associated with the frustration of not being able to communicate.
The premise of this study was that the ability to communicate is closely tied to the long-term care residents' ability to perform activities of daily living and is also central to their mental health and positive self-esteem. Successful resident adaptation requires collaboration between the family system and facility personnel. This first funded study, while small, reflects 3 themes that have characterized my research career with impaired elders. First, my research is interdisciplinary in nature, and family and staff have always been involved in the treatment and in the outcomes. Subjects in this Knoxville VA study were 36 brain-damaged residents with diagnoses of aphasia, dysarthria, or both. The sample was highly debilitated and had been without any active speech therapy for an average of 10 years. As noted in the video, they were randomly assigned to group. A repeated measures design with subjects serving as their own control was used. 2 brief individualized speech tasks were devised by speech therapists based on a comprehensive battery of audiometric and speech assessment tests. Speech tasks were implemented by trained nursing personnel during the course of care for 10 minutes daily on both the day and evening shifts and during the night when it was feasible. Let me see if I can focus that a bit better for you. Whoop. I don't know if I'm making it better or worse. During the systematic attention segment, subjects received 10 minutes daily of one-to-one interaction time with staff that was devoted to interchanges on any topic, how the Hawkeyes are doing, that sort of thing, but not speech therapy tasks. In the control periods, it was care as usual. No speech therapy or structured interactions took place. Data were collected weekly on task progress. As hypothesized, subjects performed significantly better on speech tests during the experimental or STEP segments than in either control or systematic attention segments. Age, medical diagnoses, and speech diagnoses did not differ significantly or affect speech performance, although age approached significance, with younger subjects doing better than older subjects on all speech tasks during all segments. Analysis of individual dimensions of communication ability revealed significant differences on phrase length, melodic line, rhythm, and narrative writing over time for subjects during the speech therapy enhancement segment. Once we knew the STEP intervention was effective, I added a family component to the study. In this segment, families provided memorable pictures or photos accompanied by in-person, when they could visit, or taped either audio or visual, when they couldn't visit, reminiscences. The speech therapist would then devise individualized speech tasks for the STEP intervention related to the content that was provided by the family members in pictures or on tape. For example, a sentence completion exercise might be, the name of the family dog in this photo is Sparky. In this way, family members reinforced both verbally and visually content in the STEP program, and the topics were meaningful and memorable, as opposed to boring speech exercises. Family members who participated in the experimental protocol were significantly more satisfied with the care their family member received and reported that they would be more willing to care for their family member at home should they be discharged. They were also more positive in their perception of nursing staff concern, believed they were more involved in their loved one's care, and thought the STEP intervention was effective. The inclusion of family members in the speech therapy program significantly increased their satisfaction with many aspects of residents' care, their sense of positive involvement and acceptance of the resident should they be discharged. Other findings of particular interest to me as a psychiatric nurse had to do with behavioral outcomes associated with the STEP intervention. Using goal attainment scaling ratings, subjects also improved significantly on measures of socialization and behavior, but not on goals related to activities of daily living and orientation. Now, this finding is not surprising, since the STEP intervention would not be expected to influence cognition or hygiene or eating behaviors. But it does suggest that through therapeutic one-on-one interactions for as little as 10 minutes per shift, nursing staff have the potential to improve behavior, influence socialization, and enhance quality of life of communication-impaired residents. From this early study, we concluded that even residents who have not communicated for years, decades in this case, can be helped to improve meaningful communication. In facilities where speech therapy is non-existent, infrequent, or prioritized only for those in the acute post-injury phase, rehabilitation does not have to be abandoned without any effort to remediate communication difficulties. Using the STEP intervention, the therapy can continue throughout the day, and speech therapist time can be wisely spent in diagnostic efforts, the development of individualized interventions, and the training and supervision of nursing staff and family members to deliver the intervention. The ability to express one's wishes and to communicate better also resulted in improved behaviors, such as spending more time in the day room, initiating conversation, and decreasing the frequency of outbursts and depressive behaviors. Thus, we found that in increasing the ability to communicate, we could improve quality of life for both long-term care residents and the staff who care for them.
A conceptual model developed by Jerry Hall, a gerontology clinical nurse specialist with the University of Iowa Hospitals and Clinics, PLST, Progressively Lowered Stress Threshold, identifies a decrease in inability to tolerate stress as a person becomes increasingly cognitively impaired. This model was tested and refined through Dr. Buckwalter's work at the Iowa Veterans Home in Marshalltown.
The instrument is used in several ways. The first is to assess a person who's having difficulty with behavioral problems such as wandering, pacing, agitation, and also to identify what the causative factors might be. The second thing we do is to use it to evaluate care once the care has been provided, and also in setting up programs of care both on an individual level and at a unit level or a program level. The results are very, very rewarding. We've seen patients who were frightened, who were agitated, who were frustrated, calm down, react with comfort, increase in socialization. One of the most exciting pieces of work that we did was working with group dining rooms, which, according to Linda Phillips, another researcher, are characterized by chaos. Once people are taken out of group dining rooms using the model, or the stresses are reduced in the dining room, we find people sleep all night, they gain weight, they can manage a normal tray, and their quality of life seems to improve dramatically.
Jerry Hall, who is featured in this video clip, discussed the progressively lowered stress threshold, or PLST, a conceptual model for care of persons with dementia that she developed as part of her master's program at the College of Nursing. We first published this model in 1987 in Archives of Psychiatric Nursing, and since that time, it has provided the theoretical basis for research conducted in traditional nursing homes, acute care hospitals, special care units, adult daycare settings, and homes of family caregivers. Jerry represents only one of the many bright and talented graduate students I've been privileged to work with. Not only have they enriched my career, but it is heartening to see so many of our graduates carry on this work as they assume leadership roles in geriatric practice, long-term care administration, and research.
The National Center for Nursing Research funded Dr. Mary Dean Moss, principal investigator, and Dr. Buckwalter to implement and test special unit care strategy with Alzheimer's patients based upon the PLST model at the Iowa Veterans Home.
What we found essentially was that the special care unit, unlike what we had anticipated, didn't have the effect of slowing the rate of cognitive or functional decline. We had expected that functionally we could demonstrate that residents would be better off in the special care unit environment. That did not prove to be the case. However, residents were significantly improved in terms of their agitation and their number of catastrophic reactions.
We did, however, find some differences in terms of amount of falls, restraint use, medication usage, those kinds of things that are really the hallmark of special care. With regard to the staff who received 40 hours of didactic and experiential training, we found that rather than being more burned out, as some administrators and the literature in fact had predicted, that the staff in the special care unit were better able to use their training than those on traditional integrated units, and their feelings about depersonalization, burnout, their absenteeism rates, their turnover rates were in fact lower than those who were working in more traditional nursing home units. Their knowledge levels and their satisfaction levels with their work role were also improved. So we had some very important kinds of findings that we presented in the long-term care administration literature, because we wanted facility administrators to know that putting time and money into training staff resulted in diminished turnover and attrition rates.
As indicated on the video, we were quite pleased with the results related to staff members, but we were also quite troubled by some of the data reported by family members of residents on this special care unit. Although family members reported high overall satisfaction with care, using the investigator-developed Family Perceptions of Care tool, examination of item means revealed that they were most dissatisfied with staff not soliciting their help with care, resources available for care, staff too busy to give needed care, and amount of family and patient involvement in activities. The fact that family members were less satisfied with nursing care than with care provided by other healthcare disciplines spurred us into action. And a second-generation study, the Family Involvement in Care Research Project, was born. The FIC intervention, headed by Drs. Moss, Swanson, Spake, and Reed, was funded by the National Institute of Nursing Research. The purpose of the Family Involvement in Care intervention was to decrease family and formal caregiver stress, improve family members' satisfaction with care, and also to increase job satisfaction among nurse caregivers, as well as to improve their attitudes about family members when they came to visit. The purpose of the intervention then was to develop a family staff partnership and for families to negotiate with staff their level and the nature of involvement in care. The FIC protocol was tested in 20 nursing homes in the Midwest, and the main findings are summarized on this next slide. Staff learned more about the residents because, after all, family members are the experts, and they had a lot to share. Family members, in turn, learned how they might better contribute. Satisfaction was increased, sharing was increased, and families came to be viewed as a resource for the staff rather than too often the adversarial relationship that develops. Quality of resident care was enhanced, and staff felt more hopeful, which is a very important finding.
The Abbey Center for Community Mental Health in Cedar Rapids, Iowa, is the site Dr. Buckwalter conducted the Mental Health Outreach Project, funded by the National Institute for Mental Health and the Administration on Aging. For this project, the team developed, implemented, and evaluated a service delivery model for homebound rural elders.
Well, as a nurse growing up and practicing in Iowa, I've been confronted all my life by rural settings and rural environments. During my postdoctoral phase, I was amazed to discover the real lack of services that many rural Iowans, particularly elderly Iowans with mental health problems, they simply don't have services available outside the county seat, not just mental health services, but visiting nurse services, mobile meal services, etc. And to keep an elderly person with a mental problem functioning at an optimal level in the community, you need more than just psychiatric services. You need a host or an array of services that allows them to function independently. The Elderly Outreach Project, or EOP, was a multidisciplinary mobile outreach team consisting of a core of a psychiatrist, a nurse, and a social worker. And what we did was to develop a number of screening and identification mechanisms in the community so that we had a vast community-based referral source. When we receive a referral about an elderly person whom a neighbor or a discharge planner or someone had viewed as being at potential risk for developing or actually expressing a mental illness, then one member of the outreach team would make an initial home assessment and visit. We brought that information back to the team. If it was felt that the psychiatrist, for example, needed to go out to do a workup for medications, he or she would go out. And then we would have a team meeting, collaborate, and develop a treatment plan for that individual and assign one of the members of the mobile outreach team to be the case manager for that individual. Woody.
Who is?
Hi, it's
Kitty.
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 Can I come in and see you?
I was afraid you weren't coming.
Oh, no.
Yes.
No, I had a little trouble with the lane down there. It's washed out a bit, but
It is.
yeah.
Everything's washed out around here.
We really were looking at three major outcomes. One was the efficacy of the services we delivered. The second was our ability to case find, essentially, to identify and then serve those in need of services. And the third was cost effectiveness. We had two experimental counties, Lynn and Jones County, and two sociodemographically matched control counties, Buchanan and Blackhawk County. I had a totally independent group doing the health services research evaluation. They telephoned using random digit dialing households with a member of 65 and older in the control and experimental counties and administered over the phone a battery of psychometric tests, mini mental status exams, depression evaluation, psychiatric evaluation. If one of the elderly subjects flunked the exam, for example, if they were asked who's the President of the United States and they said Herbert Hoover, then a member of the evaluation team went out into the field and actually conducted a DIS, a diagnostic evaluation survey, in home. That 3-month baseline enabled us to identify, were we picking up the people who were in need of services, who were at that time not receiving services. And we found also that we were able, through the implementation of the outreach project, to decrease recidivism rates at the State Mental Health Institute in our experimental counties, but not the control counties, and that we were able to identify and treat far more people in the experimental counties than in the control counties that had mental health services available, but in a very traditional format. You go to the mental health center and articulate a need for help with depression or memory problems or whatever. Our outreach model was innovative in the sense that we took the services to those in need of them at convenient and acceptable places.
Our evaluation of the first 2 years of the project really supported the fact that the project was effective in terms of identifying people who needed services, providing those services to them, referring them on to other needed social and medical services, and doing it in a cost-effective manner. Lots of people who had previously been unidentified and were in the community struggling with things like depression were identified and treated, and the mental illness was reversed and became a a functioning citizen again. So I believe it was very, very effective. A number of projects fell out of the Elderly Outreach Project. The one that I think has been the most substantial was the geriatric mental health training in rural long-term care settings that was funded by the Division of Nursing, that allows us to provide training to staff working in long-term care facilities around geriatric mental health topics. There's a tremendous need for this kind of training in long-term care, and we've been very successful, I think, using a train-the-trainer model in training nurses who then in turn train their own staff.
Mental health of the Rural Elderly Outreach Project is perhaps the most professionally satisfying research in which I have ever engaged. The project was designed to identify and treat rural elderly with mental problems. Let me see if I can get that a little sharper focus. The need for this type of program, however, was far from new. More than 20 years ago, the 1981 White House Conference on Aging recommended that our long-term care system should encourage support services in the least restrictive environment, especially home and community-based settings, and acknowledged that then and now they were inadequately available and inadequately funded. Practitioners and researchers alike have told us that mentally ill older adults and their caregivers need access to a variety of medical and supportive services over an unpredictable and changing clinical course. We also know that successful programs are multidimensional, multidisciplinary, and long-term, and they must integrate patient and family needs with the treatment program. The Elderly Outreach Project was all of these things. As the next slide illustrates, our outreach model included a number of community and institution-based identification sources, multidisciplinary assessment, as well as treatment and referral options. And as noted on the video, the evaluation plan focused on three main areas: case finding, service effectiveness, and cost. A rigorous independent evaluation of the project was conducted by the Center for Health Services Research prior to and throughout implementation of the outreach model. Subjects in our project were on average 75 years of age, female, widowed, and living alone. We didn't accept anyone into our project who was involved in any sort of formal mental health care whatsoever. So these were people who were coming into the system for the first time. Now let me go back to. As the project outcomes on this slide suggest, we were overwhelmed with clients. At any given time, our caseload averaged 110 older adults. We trained more than 600 gatekeepers. These were meter readers and postal workers, people who were going to the homes of elderly people on a regular basis. And we trained them on the signs and symptoms of mental illness so that they could make referrals, because they were within the fabric of the community. And these were people who were not presenting themselves to any healthcare professionals. We made numerous medical and social service referrals, and we decreased recidivism rates to the Mental Health Institute at Independence by 30% in the first year of the project alone, which kept elderly people in their home and kept county dollars at home as well. Our most common diagnoses were depression and dementia, but many of our clients had dual or multiple diagnoses, such as alcoholism and depression. 1/4 of the elders in our project had a history of chronic mental illness. We were effective in treating their emotional problems, but not surprisingly, did not alter the course of dementing illnesses. The Elderly Outreach Project was also extremely cost-effective in its delivery of quality mental health services. One reason the EOP was so effective was because it incorporated the elements of successful rural mental health systems, shown on the next two slides. In terms of the final point on this next slide, with a grant from the Apple Corporation, we were able to provide computers to our main referral sources and community-based partners, as well as a server at the Abbey Center to receive referrals. This was a particularly important aspect of our outreach program, because if we were doing our job properly, our providers should be out of the office and in the field seeing clients, rather than sitting in the office waiting to receive referrals. The EOP benefited far more than just individual patients, however. This was truly a community-based program, and the next slide illustrates the lack of services available prior to implementation of the Elderly Outreach Project. Over the course of the project, however, a number of new services were developed, such as peer counseling, caregiver support groups, and adult daycare. As these emerged, we began to build a true community-based continuum of services in Lynn County. We presented our outreach model and rich data set, both in the mental health and geriatric literature, and at local, regional, and national meetings. Our staff consulted with state and provincial governments throughout the United States and Canada, many of whom adopted or adapted the Elderly Outreach Project model to provide rural mental health services in their own regions. Regrettably, that was not the case in Iowa, where the state's mental health system and aging network were unable to cooperate and collaborate to sustain the project post-grant funding statewide. As Mary Ann Smith noted in her video clip, the Elderly Outreach Project spawned a number of other successful projects. One of these was the Geriatric Mental Health Training Series. Now, we discovered early on during the EOP that our staff would get calls, literally day and night, to provide emergency consultations to nursing home staff. Now, the timing is such that this was shortly after implementation of the Omnibus Budget Reconciliation Act, which went into effect in October of 1989, and which required decreased use of both chemical and physical restraints. Nursing homes had become what one geropsychiatrist called modern psychiatric ghettos. And nursing personnel, most of whom were unprepared to deal with behavioral problems, were absolutely desperate for alternative methods by which to better manage resident care. And thus, the three-phase Geriatric Mental Health Training Series was born. We used a train-the-trainer model, and we educated long-term care providers to better manage behavioral problems in their residents. The training series consisted of a number of core and optional models which addressed problems commonly found among nursing home residents: communication, aggressive and acting out behaviors, depression, dementia, and so forth. Over the course of the project, we trained thousands of long-term care personnel throughout Iowa. As you can see in these three phases, we started first in Lynn County, then we expanded to the AAA region, the 7-county region, and then we went statewide to more than 30 counties across the state. An independent, formative, and summative evaluation was conducted by the Office of Consultation and Research in Medical Education, looking at changes in staff knowledge, attitudes, and behaviors. To summarize the findings of this training series, let me say that the series was well received by staff. And this is on a scale of from 1 being poor to 6 being excellent. Those are the mean scores for each of the 6 core programs. And we were able to significantly increase staff knowledge of mental health issues and implementation of successful behavioral management strategies. With additional funding in years 4 and 5, we replicated the training model in the VA system, as well as in the rural South, to assure its utility with minority staff caregivers. We published the series as a training manual through Springer Incorporated, and it was a real hit nationally and internationally, such that we were very pleased to receive the coveted American Nurses Association Book of the Year Award. The training series also provided the impetus for a number of other important award-winning projects as well. For example, we received an unrestricted educational grant from Abbott Laboratories and the American Psychiatric Nurses Association to produce a video and accompanying materials called Choice and Challenge, designed to assist geriatric and psychiatric staff to better care for aggressive older adults across levels of care.
In 1992, Dr. Buckwalter received a 4-year grant from the National Center for Nursing Research for a study entitled PLST Model, Effectiveness for Rural Alzheimer's Disease and Related Disorders Caregivers. The second-generation study again tests the PLST model with Alzheimer's patients but in a home community setting rather than an institution.
The PLST model is really a conceptual model of what losses occur over the course of an inexorably progressive dementing illness. Two things happen concurrently. One, as the disease progresses, the ability of the person with Alzheimer's disease to tolerate stresses, both internal, like I have to go to the toilet, and external, like noise or large crowds of people or many decisions to make, diminishes over the course of the illness. Concurrently, the number of stressors is magnified because everything is a strange task. Everyone you meet is a stranger. So the stressors are everywhere. And so you have these two things going on. The ability to tolerate stress becomes lower. The number of stressors increases. And we believe that what happens is the person with Alzheimer's disease then crosses that kind of fine line between normative or anxious behavior into dysfunctional, catastrophic behavior when their stress threshold gets crossed. The interventions that flow logically from this model then teach the caregiver ways to diminish stress in the environment and to provide respite periods from stress essentially during the course of the day. You'll never eliminate stress because getting dressed, eating breakfast, all of those things are stressful for the person whose memory is impaired and who has cognitive and perceptual difficulties. But what we do is to help them to find ways to make, say, bathing less stressful and to counteract high periods of stress, like a congregate meal, with a rest period where the lights might be dim in a nursing home and there'd be no visitors for a 40 to 90-minute period. So what we do is then, as stress builds, look at ways to diminish that so that there won't be an accumulation of stress and the person just loses it, say, at the end of the day. And then a term we use is sundowning, where they become acutely confused in the late afternoon, early evening hours, very agitated.
With support from the National Institute of Health's then National Center for Nursing Research, we developed an in-home psychoeducational intervention based on the PLST model, which we then tested with rural family caregivers. Although originally proposed for only rural Iowa and the Rochester, Minnesota area, after 2 years we had enrolled no minority caregivers. So we expanded to include sites in Minneapolis, Indianapolis, and Scottsdale. The aims of the project were to evaluate caregiver responses to their caregiving situation. We wanted to identify changes in their knowledge levels, their burden, their satisfaction, their sense of mastery, and impact, which is their assessment of the amount of intrusion caregiving places in their life. We were also secondarily interested in a variety of care recipient outcomes, including physical measures such as weight, but primarily behavioral measures such as agitation, confusion, and use of medications and restraints. Over a 3-year period, 245 dyads were enrolled in the study in either the experimental or comparison group. Caregivers had been providing care for an average of almost 10 years. They provided nearly 18 hours of care per day, or 122 hours per week, and yet received only about 4 hours of respite care for themselves each week. Most care recipients had a diagnosis of Alzheimer's disease and were quite well advanced in their dementia, with global deterioration scores in the moderate to severe range. The average care recipient was 76.5 years of age, and their caregivers, who were mostly female spouses and adult children, were themselves quite elderly, averaging 64.6 years of age. Subjects in the comparison group received routine information, referrals, and a copy of the 36-hour day, which was a leading family guide at that time. They also got a caregiver notebook with informational brochures similar to that received by caregivers in the experimental group. We hypothesized that caregivers who received the PLST intervention would report less depression, a greater sense of mastery and satisfaction, and less caregiving burden. Using the Philadelphia Geriatric Center caregiving appraisal scales and a hierarchical linear modeling approach, we found we were able to decrease caregivers' sense of impact or intrusion on their life, decrease burden, and increase caregiver satisfaction. But the PLST-based intervention had no influence on caregiver mastery. In terms of frequency of behavioral problems and caregiver relations to those reactions, to those behaviors, which we measured using the Zaret Memory and Behavior Problem Checklist, we found that the intervention effect varied according to relationship, that is, whether they were a spouse or an adult child caregiver, and that care recipients' activities of daily living did not vary by group. Caregiver response to behaviors was also affected by their relationship, that is, spouse or child, to the care recipient. Using two instruments, the profile of mood states and the geriatric depression scale, we found that caregiver depression levels were positively affected by the psychoeducational intervention. Thus, the PLST caregiver training module had the potential to reduce the risk of caregiver depression, improve tolerance and capacity to care for patients in the home. And this should be our last video clip.
My interest in special care units has continued on from the research with Dr. Moss at the Iowa Veterans Home. The Alzheimer's Association approached me and Jerry Hall and a team we've assembled here at the University of Iowa to continue to look at perceptions of special care units, which is the most highly growth industry within long-term care. They're proliferating like mad, and nobody really knows what's special about a special care unit, what makes a good unit, etc. So we are evaluating the perceptions of state ombudsmen nationally who do a lot of the interference for families and others who have problems in the long-term care industry. They act as patient and family advocates. We're also looking at directors of state agencies who license and who receive complaints about nursing homes, those with and without special care units. But most importantly, we're evaluating the perceptions of family members because, as I said, they're the experts here, and they really have a good handle on, are they satisfied with the care? Were they misled by a brochure that promised something, special activity programming or something like that, that the unit didn't deliver? You know, they're a very vulnerable group as well as being a knowledgeable group. By the time they make a placement decision, usually their family member is well advanced in the disease. Their behavior has become uncontrollable in the home setting, but there's still a lot of guilt and sometimes resentment associated with that placement decision. Many families feel guilty because they've abandoned their loved one. They promised till death do us part they would never do that. So there are a lot of emotions surrounding the placement decision, and families are really the experts when it comes to evaluating the quality of care that's being given in the long-term care setting. So we're soliciting their opinions.
What she does first is bring visibility to us. Because Iowa is a state with the third highest percentage of people over 65 and the first highest percentage of people over 85, obviously the work that she does is needed in this state. And one of the things we're always concerned about is that we make our science appropriate for the needs of this state. We think that her work is going to do something that will improve access to health care and improve the quality of health care as she helps us to know more about what should be done with the elderly.
Research is an important mechanism for improving quality of care. Particular patient population I deal with, mentally impaired elderly, are among the most underserved in the world. We really need more research to understand the nature of their problems and the ways to deliver quality of care to this particular population, and I'm happy to be a part of an effort to do that.
Goethe's last words serve as a call for the development of more innovative elder care projects and health services research to determine the organizational and economic obstacles that impede reliably excellent care for impaired older Iowans. They also serve as a particular plea for enlightenment on the part of our state leadership and legislature to stop draining the Senior Living Trust Fund, and especially the Senior Living Program, to undertake a restructuring of the archaic mental health system in Iowa, and to support home and community-based services that will allow older Iowans to live their lives in preferred settings with compassionate care, dignity, and enhanced quality of life. Unless you think that I'm the only one who thinks we have a problem with our current system, I offer this recent quotation from the opinion page of the Des Moines Register. Can you read that? Okay. Those squalid boarding homes warrant attention. The focus should really be shifted to address the fact that Iowa has not given mental illness the attention or funding it warrants. Increased subsidies, better regulation, and more caseworkers are the route to increasing the quality of life for the mentally ill in Iowa. And that was just this past month. In fact, 10 years ago, in 1991, the 74th Iowa General Assembly charged University of Iowa hospitals and clinics, and I'm quoting here, to conduct a study to develop recommendations for providing a continuum of statewide geriatric care from acute hospital to long-term institutional care, as well as community-based care that meets the unique medical, emotional, economic, and social needs of the geriatric population of Iowa. And on page 40 of that report, under the section entitled Gaps in Service, concerns were raised about the availability of geropsychiatric services and the geographic accessibility of those services with a limited number of inpatient beds concentrated in the southwestern quadrant of our state at the Clarinda Mental Health Center. Limitations were also identified relating to the care of patients with Alzheimer's disease and the financial disincentives to care for these patients. A number of excellent recommendations were set forth in this report. Sadly, few of them have come to fruition. Faculty at the University of Iowa therefore have a continuing obligation to better understand and correct the reasons for inadequate application of existing knowledge to the provision of accessible, effective, and affordable care. If we are serious about assuring a healthy and prosperous old age for all, then we must push for a healthcare system that meets the needs of older Iowans and addresses the looming national crisis. This can best be done through application of health-enhancing and preventive measures, research to determine best practices, and through education of the workforce, as we are doing in our Geriatric Education Center, the Reynolds Foundation grant, the Hartford Center for Geriatric Nursing Excellence, and the Gerontologic Nursing Interventions Research Center at the College of Nursing, as well as our Center on Aging. Despite the fear that managed care is eroding the nation's research capacity and undermining the social missions of many academic health centers, an important part of our goal at Iowa must be to change the attitudes and knowledge of providers, to advise policymakers, and to continue to conduct research and translate that research into practice, using the information we already have concerning home and community-based services throughout this state. We can do better. And as noted by Frank B. Serra, Senior Vice President of Health Sciences at the University of Minnesota, we need to understand the mechanisms of aging and to look for opportunities to intervene constructively. Taking care of seniors requires the interaction of physical problems with those of emotional, social, and economic spheres. Far too many older Iowans needlessly suffer physically, economically, psychologically, spiritually, and socially. Their preferences concerning care are too frequently ignored, and their families and caregivers are often left in emotional despair and financial ruin. So who will care? It must be us. I want to especially thank my family for their love, support, and patience over the years. I also want to thank the many teachers, staff, administrators, practitioners, students, colleagues, and mentors who have made the projects highlighted here today possible. I especially want to thank my office staff, Linda Hartzler, Karen Brunk, Anthony Cervini, and the Med Photo staff for help with slide production, Joe Elan for loaning me some photos, and the staff at the Video Center for help with the video clips. Finally, I want to dedicate this lecture to my parents, Bill and Gertrude Cohen, who encouraged my educational interest from the beginning, who cared for our children while I was finishing my doctorate in Chicago, and who are a constant and personal reminder that the development, delivery, and evaluation of high-quality elder care services is far more than an academic exercise. I also want to dedicate this presentation to the staff members at Family Medicine, Liberty Country Living, Atrium Village, and Hospice of Iowa City, who provided excellent care for my late father over the past several years, and who, when asked the question, "Who cares?" can truthfully respond, "We do." Thank you.